Yeah. Good morning, judges. So I'll be presenting my paper on cerebral visual impairment, our perspective. CVI has become the leading cause of bilateral visual impairment in the Western world. And in India, its prevalence has increased in children less than 3 years of age, and it has exceeded the cause of congenital cataract and ROP and has become a significant public health problem. Any damage to the visual processing area causes cortical visual impairment. It comprises of visual malfunction due to retrochiasmal visual and visual association pathway pathology. It can be seen isolated, or it can accompany anterior visual pathway dysfunction. So the aim of our study was to understand the causes, the radiological features, the prognosticating factors, and impact of timely visual rehabilitation. So it was a prospective study done between Jan 2012 to December 2022. Patients included were children who did not, in whom the ophthalmological findings did not explain the visual performance. There was history suggestive of a stormy perinatal period and associated neurological pathology. So all children underwent a thorough evaluation, including a detailed history, age-appropriate vision assessment, keeping the cognitive ability of the child in mind. MEM retinoscopy was done to look for the accommodation insufficiency. Intraocular pressure assessment was done. Squint and ocular motility assessment was done. They underwent cycloplegic refraction. Anterior and posterior segment was evaluated. Pediatric neurology opinion was taken and underwent neuroimaging. And finally, all the parents were counseled regarding the child's condition. So all children were advised to review after 3 days with the required optical correction for functional vision assessment and planning of the vision training strategies. Children who had ocular visual impairment were treated with adequate measures wherever indicated. We had 199 children, of which majority were boys. The commonest mode of delivery was normal, and we had 87% who were term delivered. The age range was 1.5 months to 216 months, with a mean age of 34.5 months. Almost 70% were less than 3 years of age, and 40% were less than 1 year of age. And majority of the children were referred to us by the pediatrician and the pediatric neurologist. The functional vision impairment was classified into 7 levels, with 0 being no perception of light, and level 1 to 6 based upon the Hoyts et al. Classification. 1 is perception of light ranging to 6, which is normal visual acuity. Accommodation insufficiency was seen in 5% children. The commonest refractive error in our cohort was compound hyperopic astigmatism, which was seen in 35% children. Exotropia was seen in almost 62% patients, 20% had nystagmus, and more than 50% had optic dyspallor. CVI with ocular visual impairment was seen in 76% children. Of this, 79% children underwent vision training. The commonest cause in our cohort was perinatal brain injury, followed by hypoglycemic brain injury. And the commonest neurological abnormality was global developmental delay, followed by seizures, cerebral palsy, microcephaly. And the associated anomaly, the commonest was congenital heart disease. On neuroimaging, the commonest feature seen was hypoxic ischemic encephalopathy and periventricular leukomalacia, followed by parieto-occipital gliosis. So after visual training, we noticed that almost 11.5% children were high functioning, whereas the rest were low functioning. Of 199 children, 79% underwent visual training, 66 came for follow-up, and there was 1 or 2 level improvement seen in almost 35% children. However, 21% failed to review. So we know that occipital lobe is where the major information comes, and from there the higher visual processing takes place en route to the frontal lobe. The occipitotemporal pathway is responsible for the recognition of object, and occipitoparietal pathway is responsible for spatial processing. The spectrum of CVI can range from very low functioning to very high functioning. The most common cause in the series was HI, which is in accordance with the other studies done in India. 70% children were less than 3 years of age, and this first 3 years are very crucial for the child's overall development. Majority of children were referred, so we know that there is a role of pediatrician and pediatric neurologists in identifying these children and timely referral to us. 48% had very low vision ranging from no PL to PL, and this highlights the implication this condition can have in declining the overall child's development. The commonest refractive error was compound hyperopic astigmatism. Dyspallor was seen in more than half of the children, but it was not associated with any other ocular cause. So the likely cause here is retrograde degeneration. 5 children had bilateral visually significant cataract who underwent surgery. HIE was a commonest etiology, and GD was a commonest neurological manifestation. Abnormalities on neuroimaging were seen in 97% children. So we had almost 11.5 high functioning CVI. These children go to regular school and often have normal visual acuity, but they can have issues with learning difficulty, decreased scholastic performance, and trouble in sports and socializing. These children are often missed in the regular OPD because of better visual function, but clues in the birth history and asking leading questions about the scholastic performance could help. 21%, despite being diagnosed, they did not undergo vision training because the parents failed to follow up. Many patients were also lost to follow up as they belong to other states and hail from a different country. So establishing easily accessible CVI centers across the country could help. So we believe that a thorough CVI assessment at least once could help initiate a therapy, create awareness to the caregivers, and improve quality of vision and promote better follow-up. So I would like to conclude that an emergent need for a comprehensive eye evaluation in any child who has a stormy perinatal period. It requires a multidisciplinary team. Timely intervention for correcting the treatable ocular causes is a must. Creating awareness in the community is the need, and providing various therapies at economical rate under one roof is very, very important in bridging the gap in this predicament. Thank you. Ma'am, the whole idea behind presenting this paper was that everybody talks about the causes, but nobody actually talks about how many children actually end up coming to you for subsequent follow-ups. So the stress was upon this that we should also highlight how we can encourage these parents, counsel them, and make sure that they come for regular follow-ups. As I mentioned, as you must have seen, the study is over a period of 10 years. So in children with CVI, you won't ever see instant improvement in the vision. So you have to follow these children over a period of decades to actually see whether they have improvement. And even one level improvement makes a big difference to the child's life. So the idea is to promote a message that we have to start creating awareness. Don't miss out these children. Some may appear to be normal, but there could be certain clues. So taking a detailed history definitely helps. And if you're seeing any children who has a stormy perinatal period, the first 3 months of life only we should make sure that they undergo a eye evaluation, and preferably with a pediatric ophthalmologist, because they would be able to catch these children early on. And yeah, but somehow what I've seen is they are the ones who are actually referring. So yeah, in the pediatric neurology. Yes, absolutely.